the last virtual meeting, we were pretty much getting to grips with the coronavirus pandemic, and we were the main things that were sort of occupying us at that time really were issues around shielding, issues around would there be vaccines, and of course, I guess most of you now have all been vaccinated. And we know an awful lot more about the coronavirus. And of course, this little electron micrograph here is a picture of the severe acute respiratory syndrome coronavirus type 2, or a virus that causes COVID-19. This is a type of coronavirus which is similar to other viruses that have caused human disease in the past. So the SARS virus, severe acute respiratory syndrome, and Middle East respiratory syndrome viruses were all coronaviruses. They caused a bit of a ripple, but actually didn't spread in the way that this one has. And as you know, the current coronavirus has a whole range of features, from going from an asymptomatic thing that people don't even know they have, to a very severe respiratory problem, causing respiratory failure and sometimes death. Next slide, please. After a year since we sort of last spoke at one of these meetings about coronavirus, an awful lot's changed. We've got much better knowledge about the natural history of the disease, about the outcomes, about how to use public health measures more effectively. We now have treatments that reduce the severity and improve outcomes, such as the steroid dexamethasone, the anti-inflammatory rheumatic drug tocilizumab, and the antiviral drug remdesivir, all been proven to improve outcomes in different ways for people with severe COVID-19. And we now have at least 3 effective vaccinations that are being used in the UK. What we really don't know, and is of interest to the current audience, is what the outcomes are for women with LAM who get coronavirus. And there's been a suspicion for quite some time that people with respiratory disease would do worse if they got coronavirus than people who didn't have respiratory problems. The other issue for women with LAM, of course, is will rapamycin make my coronavirus infection worse? And at first we didn't know whether we should stop rapamycin, and certainly the mTOR inhibitors that we use for tuberous sclerosis were stopped by lots of tuberous sclerosis physicians. So we wanted to try and understand whether women with LAM had a standard outcome for coronavirus, or was it more severe? How was the severity of how your LAM related to the outcome from coronavirus, and really did rapamycin affect any of that? So next, if we move on, next slide, please. So as you all know, the outcomes from coronavirus may vary, and up to 45%, nearly half of people might have no symptoms at all. And the remainder have a relatively mild illness that's self-limiting. A small number of people, between maybe 3 and 10%, have a more severe illness requiring hospital admission. And 20% of these have a severe disease with lung inflammation or pneumonitis, similar to acute respiratory distress syndrome, which you see in bad sepsis or after trauma, or really any severe lung injury. And the initial data from studies did suggest that people with lung disease were more prone to getting this severe form. But really, there's never been any specific data on LAM. So, of course, now, maybe 18 months into this thing, women with LAM have had coronavirus. And the CT scan that you can see on the right of the picture is somebody with mild LAM. The blue arrows highlight the LAM cysts. There's a couple more around, but you can see there aren't many cysts in this picture. This is someone with pretty mild LAM and normal lung function. But the yellow arrow is pointing to this fluffy white area. That's an area of lung inflammation caused by coronavirus. And so this woman had coronavirus pneumonitis and actually ended up in hospital for a couple of weeks, but actually has made a good recovery. So we now have experience of women with LAM getting coronavirus. And so really the advice has always been to be more careful, whatever that means, because I think most people with LAM have been being pretty careful anyway. If you have more severe disease, if you're older, if you're from a Black, Asian or other ethnic minority background, we know that people from these backgrounds are more prone to severe infection. We also know that people who are overweight, especially if your body mass index is more than 40, are much more likely to have more severe disease, and so are those with diabetes and some other illnesses. So really that had been the advice up to date. So next slide, please. So what we wanted to do really is to improve the advice that we gave to people. People with LAM were pretty good at shielding, I think. And it became fairly obvious that to find enough people, LAM researchers had to get together a bit. And so Bruno Baldi, who's a LAM physician in Sao Paulo in Brazil, as you probably know, Sao Paulo has been the epicenter of the coronavirus pandemic in Brazil, and they've been hit very hard. How he gets the time to still do research, I really don't know. But Bruno Nishant Gupta, who you're going to meet later on, who's the scientific director of the LAM Foundation and oversees this big network of LAM clinics in the US, and myself from the UK LAM Centre, got together to try and collect as many patients with LAM who'd had coronavirus as we could. And it was an unorthodox methodology. Really, we just phoned our friends who are other LAM doctors in other countries. And between us, we've found, I think, coming up for 100 women with LAM across the world who've had coronavirus infection. Today, I'm just going to present data on 47. We haven't analysed all of the data from the study yet, so I've looked at the data that we've got mostly from the USA, Europe, including the UK, and I think that's it, in fact. And most of our patients have either come from the LAM Centre here, a few from Cincinnati, from Nishant, but also from Elżbieta Radzikowska, a LAM doctor in Poland, Sergio Harari, who works in Milan and runs a big LAM centre there, Vincent Cotin in Lyon, France, who's a rare disease specialist there. So we found 47 women with LAM who'd had coronavirus infection. The coronavirus were all confirmed cases. There were quite a lot of other people who had coronavirus, we think, but we weren't able to include because we weren't sure. And so there were people whose partner got coronavirus, then they got the same symptoms 5 days later, but didn't have a test, maybe because they were too ill to go out or didn't feel too bad and didn't bother. So they probably had coronavirus, but they couldn't be included. So these are the people who had the diagnosis confirmed, actually. So we might be looking at the more severe end of the infection. So 45 of these people had a positive PCR test. One person had negative antibodies, got ill, and then had positive coronavirus antibodies, so seroconverted. And one person had clinical features and a lung CT consistent with severe coronavirus pneumonitis. Our patients in this part of the study came mostly from the UK and Poland, with, as I say, a few other patients from the USA, France and Italy. Because ethnic origin affects outcomes, we looked at that. The majority of patients were white, sort of reflecting a bit the populations of the centres, with a smaller number Afro-Caribbean and some Hispanic. So next slide, please. So we already know from other studies about coronavirus generally that those people who get more severe infections tend to be older. They tend to be from non-white backgrounds. They tend to be more likely to be overweight. They might have chronic kidney disease, heart disease. People with organ transplants, sickle cell disease, and pregnant people are particularly at risk of worse disease, and also smokers are. So the figures on the right are those values for the cohort that we looked at in this study. So like most studies of women with LAM nowadays, people were relatively young, 47 years old, but that ranged from 23 to 71. As only 13% of them were non-white. A quarter had a body mass index over 30, so that's in the obese range, not the very obese range. 8.5% of them had kidney disease. Those are mostly people with tuberous sclerosis who can also get kidney disease from that. And only one of them was an active smoker. So next slide, please. So for these women, a few facts about how bad their LAM was. The average duration of LAM from their first symptom was 74 months, although there was a wide range from 6 months to over 300. The lung function was impaired. So their FEV1, the average FEV1 was 74% of predicted. For FEV1 and gas transfer DLCO, 80% is about the bottom of the normal range. So they had slightly reduced FEV1 values. Like most people, the gas transfer was a bit lower than the FEV1. So this was a standard group. You will notice from the ranges that 1 or 2 patients had really quite severe LAM with gas transfer of 17% and FEV1 of 36%. Half the patients roughly were taking an mTOR inhibitor, and they'd been on it for about 4 years or so, and most people were on 1 or 2 milligrams. Like our LAM Centre cohort, 17% of the cohort had TSC LAM, but the majority had the sporadic form of the disease. So I think we had a good cross section of different types of people with LAM that were included in the study. Next slide, please. So the symptoms of coronavirus in people with LAM in descending order here were pretty similar to anybody else with coronavirus infection, really. Most people had fatigue, fever, cough, loss of appetite was common. Only about half of people were more breathless. I thought that might be more than that. Half of them had a headache. And the other things like loss of taste and smell were a little more, were a little less common. Next slide, please. There was a spectrum of severities. Only one person was completely asymptomatic, and they were diagnosed when they were screened at a hospital visit, and they had a positive PCR test but no symptoms. The majority of people had a self-limiting illness and stayed at home. Didn't need any specific treatment, but may have been quite poorly. And I certainly know one of our patients sounded reasonably unwell at home and perhaps should have gone into hospital but didn't, and was fine. 31% of patients were admitted to hospital. So these were the ones with the more severe disease. And in fact, 2 of the patients were in hospital for other problems and got coronavirus while they were there. If you look at the little pie chart there, the blue bits of the pie are the ones that sort of didn't need much treatment and got better on their own. The red bits of the pie were the people who had more severe illness. And you can see, so well over half of people, although they might have been poorly, didn't need any particular treatment and recovered well. None of the people in the UK have died. There was one person that died out of the whole 47. This was somebody from Europe who was 59, had very low lung function, was on continuous oxygen therapy, and also had pulmonary hypertension, a severe complication of long-standing LAM, where the pressure in the lungs increases. We don't see this very often, but it's a marker of a severe phenotype. And unfortunately, she died, but she was the only one in the study. Next slide, please. So if we concentrate a little bit on the hospital admissions, so as I say, 14 patients from the study, 31% of the whole group had to come into hospital. The average length of stay was just over 2 weeks, but that ranged from just 1 day to a whole month. All of the people that got admitted needed supplemental oxygen, and really that was the main reason for them to going into hospital. Only 2 of these people needed any form of assisted ventilation, and neither of these were UK patients, actually, for what that's worth. One of these people was intubated and put on a normal ventilator. The other had one of these non-invasive devices with a face mask that supports breathing. Most people had some form of drug treatment, and because this was done over the time of the pandemic, this has pretty much evolved to keep up with the improvements in care that we've had. So half of the people had steroid treatment, so usually dexamethasone, which reduces the reduces death rates in people who have coronavirus significant enough to need oxygen. A fifth had the antiviral treatment, remdesivir. Heparin, which prevents blood clotting, which is a big problem in severe coronavirus infection, was used in over 1/3 of people. Most people got antibiotics. Some people didn't get any drug treatment. One patient in particular, because she was admitted with diarrhea, went home the next day and was only told after she'd gone home that she had coronavirus infection, ended up having no specific treatment. So next slide, please. So some of the important things to think about are you know, what was the overall outcome really? Well, as I've said, only 1 patient died, and it's not really only 1 patient, but of the whole study of people with lung disease, 1 death in somebody with really quite severe disease would be perhaps an expected outcome, unfortunately, for a serious illness like coronavirus. About 15% in total needed to increase their oxygen after they were either discharged from hospital or after the disease subsided. 1 person had a pulmonary embolus, a blood clot which travelled to the lungs, and we know that increased blood clotting is a complication of severe coronavirus infection. 1 person had a pneumothorax. Actually, I think the patient probably had a pneumothorax and then got coronavirus during the treatment for it rather than the other way round. So I don't think COVID really causes pneumothorax in women with LAM. So the last column is long COVID. Now, it's called long COVID on the graph. We don't really know how to define this. And what we've done here is we've taken anyone who's had persisting symptoms after discharge, whether that be fatigue, headache, or transient increase in breathlessness. What we haven't done now is followed people up for a longer period. So these values look high, but actually, I think because we used quite a stringent way of defining this, it's likely to fall as the weeks go by, and we know that some people have really quite long-term symptoms from coronavirus, but a lot of these symptoms gradually improve over a few weeks. So next slide, please. So one of the important questions really was, what is it about people with LAM that means that they're going to get a more severe infection? You know, is there anything specific? So we looked at lots of the factors that were usually associated with more severe coronavirus infection, like age, ethnic origin, etc. And we also looked at features associated with LAM. And so what I've done in this table is I've compared people who didn't need to come into hospital, which I've called home care, to people who did go into hospital. So if we say that severe infection is associated with hospital admission, we've used that as a marker. Now, the p-value in the column on the far right is a statistical measure of how likely it is that that this is due to chance. So if your p-value is less than about 0.1, that means there's a less than 10% chance that that this is just a spurious observation. Normally, you would correct the p-values for comparing lots of different factors, which I haven't done yet. But when we do the bigger study, we'll do this slightly more carefully. But I think this gives a good look-see. The ones I've highlighted in bold look like they might be more important factors. So the people who went into hospital were about 8 years older than the people who stayed at home, and that looked like that might be a significant thing. Of course, we know that people who are older are more likely to have more severe coronavirus infection. The time since diagnosis of LAM, further down the column, was also quite a lot higher, 102 months compared to 60 months in the people who went into hospital. Now, of course, this might just be because they're older. It might not be because there's something about having a LAM for a long time, but we haven't got enough people to tease that thing out. The more people that went into hospital were overweight than people who were looked after at home, and again, this is a standard factor. We didn't really have enough people to make give a very clear answer on the effect of diabetes, chronic kidney disease, or sporadic versus TSC LAM with hospital admissions, but they look reasonably similar. It may be if we had a lot more patients that these factors would become clearer. So in terms of lung function severity, then that was there does seem to be a signal there. So if you look at the FEV1 and the DLCO values, you can see these were both lower in the people who went into hospital compared with the people who didn't. DLCO particularly was significantly lower. There was a bit of a trend that the FEV1 was lower. So perhaps more severe disease is associated with hospital admissions, and you might expect the people with lower DLCO values, a gas transfer value, to have lower oxygen levels and need to be in hospital. There was no difference. Oh, can we go back, please? There was no difference in the whether you were on an mTOR inhibitor or the dose. And the mean number of symptoms in both of the from coronavirus was the same, and most people had about 5 things of anorexia, breathlessness, fever, that sort of thing. Next slide, please. So the other important question really is, does being on rapamycin or any mTOR inhibitor affect the severity of your illness? So we looked at the outcomes for people on an mTOR inhibitor and not. So, of course, the reason people are on an mTOR inhibitor is usually because their LAM's worse. So you've got to factor in the outcomes. And if you look at the on the mTOR inhibitor, they compare with not, then the FEV1 and DLCO values are both lower in the people receiving the mTOR inhibitors. Obviously, they had more severe illness, and that's why they were on the drug. So does being on the drug affect the coronavirus severity? Well, they had the same number of symptoms, roughly. And about the same number went into hospital. So 26% of the no mTOR inhibitor cohort went into hospital, 33% of the mTOR inhibitor cohort. And that's not a significant increase, bearing in mind the small numbers. The long COVID or the post-coronavirus symptom burden was about the same in both groups. The person who died had much more severe disease, and she was on an mTOR inhibitor, but as we can't say whether that was a significant thing because, as I say, it was only one patient. So it doesn't look like being on an mTOR inhibitor really affects the outcome for women with LAM. So how does this compare with other lung diseases, or in fact other people without lung diseases? So it's pretty hard to say at the moment. What I've done here is I've looked at a study that Geesley Jenkins and his group did, looking at the outcome of interstitial lung diseases in people who got coronavirus infection. And all I've shown you here is the data for women to try and compare them with the LAM patients. And the top graph is the in-hospital mortality for women without interstitial lung disease of these different ages, under 60, 60, 75, over 75, compared with people who had interstitial lung disease. Now, actually, the outcome was much worse in men. But if you have interstitial lung disease, your outcomes tend to be quite a lot worse. 1.6-fold increased risk of death than people of the same age and the same other number of problems without interstitial lung disease. The little thing on the bottom, I've just tried to construct the same type of graph from our data to compare a little bit. And so you can see that, we only had one person died with LAM. It's only a small sample, and they're not directly comparable. But I just wanted to show you that I don't think that LAM makes the risk of dying from coronavirus any higher than actually anyone else, pretty much. Particularly, if unless you have the more severe versions of LAM. Next slide, please. So in summary, I don't think the outcomes for women with LAM are very different to other groups based on this relatively small sample. We'll get a slightly better example when we looked at the whole data set, which is twice as many people. Risk factors for more severe infections and hospital admissions seem to be increasing age and possibly disease duration, really like any group really. Higher body mass index and lower lung function, probably especially DLCO. Doesn't look like rapamycin has any bad effect on coronavirus severity. So next slide, please. So the recommendations, I think, would be that everyone should continue being careful and maintaining their social distancing and hygiene measures. And one of the things that the pandemic's taught us is that by doing the social distancing and being stringent with hand hygiene, etc., there are lots of benefits on not getting respiratory infections, and many people with LAM and actually lots of other respiratory diseases that we look after, people have had a much better winter without other virus infections and have actually felt reasonably well. There's no reason to stop your mTOR inhibitor, either rapamycin or everolimus. And of course, if you haven't been vaccinated by now, you really should get vaccinated, because the vaccines are much safer than getting coronavirus, that it's very important that we all get vaccinated. So, what are we doing at the LAM Centre? Well, we've given a lot of advice and support phone calls. We're changing our care model a little bit to do more video consults and phone consults than we were previously, and trying to work out how to safely monitor people remotely, so we can still look after people as well as possible, but minimize their risk of getting coronavirus. In fact, the LAM centres, because it's a bit separate from other hospital clinics, it's very easy to socially distance there. We're prescribing more remotely and really trying to plan how we're going to look after people in the post-COVID era. And that may include home monitoring of lung function and other things, but there's a bit of work to do around that.